Good day, everyone. I'm Dr. Dalandag, and I'll be giving you the pre-lab on the female gut. Please make sure that you have Robbins beside you while you're viewing and listening at the same time. As a review, your cervix has two portions. You have your exocervix, the one which is lined by your stratified squamous epithelium, and you also have your endocervix, the inner portion, the one which is lined by your columnar epithelium. First slide will be the carcinoma in situ. Carcinoma in situ means the dysplastic changes have already involved the full thickness of the epithelium, or the immature squamous cells, which are supposedly normally found only at the basement portion, have already reached the topmost portion as well. So instead of maturing, it will remain immature. This is found in the textbook, and I believe this has also been discussed in the lecture already. So I hope you still recall what we discussed in the lecture. Just to compare the normal from CIN1, CIN2, and CIN3. The normal lining epithelium, as you can see, it will have lighter colored structures once it will start to rise from the top. And the immature squamous cells, which are dark in color, will remain in your basement membrane. You compare it to the one beside it, CIN1. One-third of the immature squamous cells have already gone up. In CIN2, the immature squamous cells will occupy two-thirds to one-half of the lining epithelium, or one-half to two-thirds of the lining epithelium. And in CIN3, the entire length or the full length of the epidermis will now be occupied by your immature squamous cells. So if you try to compare the normal with CIN3, just by looking at it, you can see that there is a difference in the color already in CIN3. CIN3 appears dark blue, while in normal, it appears lighter as it goes up. This is an actual slide in the laboratory. The ones that are pointed with the red arrows, those are your endocervical glands. Endocervical glands are supposed to be found in the endocervix, and normally endocervix must be lined with your simple columnar epithelium. In this specific slide, your lining epithelium present in this portion here is still your stratified squamous epithelium. Take a look at the color of the squamous epithelium here. Compare it to the one right about here. The one with the red circle, or the red spherical shape structure, that is your normal squamous epithelium. The second circle, the second blue circle, that is already your dysplasia. Compare the difference in the color between the first blue circle, the red spherical structure, and the second blue circle. You can see the difference in the colors of the three areas that we have encircled already. The third circle, the second blue circle, is very dark already because the entire length of the epithelium have immature squamous cells. So this was the first blue circle area. You have immature squamous cells, which go up until about two-thirds of the epithelium already. So if you're going to grade this one, this would be CIN2. While this will be your CIN3. You will have dark blue squamous cells, and there are even cells wherein you can appreciate nucleoli, such as this one here. The tiny blue dot would be your nucleoli. Also, again, the entire length of the stratified squamous epithelium will be occupied entirely by your immature squamous cells. That's why the cells that you see in front of you are big, dark blue, and almost of the same size because these are all immature squamous cells. This type of neoplasm, although already considered malignant, it has not yet invaded the underlying mucosa. That's why you still call that in situ. For squamous cell carcinoma, this is the time wherein the atypical squamous cells will have already invaded the basement membrane and have reached the mucosa already. And the most common risk factor for this type of malignancy in the female genital tract will be the high-risk HPV oncogenes, such as your high-risk oncogenic HPV, such as your 16 and 18. There will be transition from dysplastic squamous epithelium, the one encircled in red, to invasive squamous cell carcinoma, the ones pointed by the black arrows. So it will start from something dysplastic and then eventually it will progress to invasive squamous cell. And these are the malignant nests and tongues of cells, specifically your atypical squamous cells, and they are already found in the underlying stroma. Once it has already invaded, you will call that your invasive squamous cell carcinoma or squamous cell carcinoma. So you have your atypical cells, which have pleomorphic nuclei, prominent nucleoli, and numerous mitotic figures. So you have very big, you have a quite small nucleus, and then you have your prominent nucleolus or nucleoli. The ones pointed by the red arrows. And the ones pointed by the dark blue arrows, those are your mitotic figures. Next slide will be leiomyoma, benign smooth muscle neoplasms, and the most common neoplasm found in the female genital tract. These benign neoplasms are sharply circumscribed, discrete, round, firm, gray-white. It can vary in size from being very small to becoming very large, and malignant transformation to leiomyosarcoma is extremely rare. So leiomyosarcoma will not technically arise from your leiomyoma. So this is what you call well circumscribed, okay? Because you can clearly see the separation from the benign, this one, and your from your normal, and from your benign tumor, the one encircled in red. And for the one on top, this will be your leiomyoma, that one, this one, and etc. Okay, because there are so many here. Most of the time, they appear multiple. So this is the microscopic portion. The one with the star, that is your normal epithelium, that is your normal tissue. The one that I pointed with the blue arrow, that is the separation between your benign tumor and your normal tissue. Again, normal tissue is the one with the red star, and your blue arrow, the one which shows you the separation between the benign neoplasm and the normal tissue. While the one that I pointed with the black arrow, those are your smooth muscles, found inside your neoplasm. Remember your leiomyoma, these are your benign smooth muscle tumors. So expect to see smooth muscle within the tumor. And that is your clue that you're looking at your leiomyoma. So there is proliferation of smooth muscle that resembles normal myometrial tissue or muscle. So your myometrium is composed of smooth muscle, blood vessels, connective tissue, and sometimes inflammatory cells. So this will be your smooth muscle, and this would be again your clue that you're looking at your leiomyoma. And that is what you call your whirling pattern. WHORLING. The smooth muscle cells have uniform appearance, and the nuclei, the ones that I encircled in blue, are oval to elongated. Now the malignant counterpart of your leiomyoma, which is your leiomyosarcoma. Again, they will not arise from your leiomyomas. And you have also MED12 mutations, the same as your leiomyoma. They spread or metastasize via blood vessels. And the most common organs that they invade or metastasize to will be the lungs, the bone, and the brain. You can clearly see the difference here between your benign leiomyoma and your malignant leiomyosarcoma. So if your leiomyoma, they are firm, nodular, grayish white, tan white type of tumor, your leiomyosarcoma are soft, friable, easily crumbling because they're very soft already because they are full of hemorrhage and they are full of necrotic portions already, which is not found in your leiomyoma. So just by looking at the gross organ or the gross picture, you can already see the difference between the benign and the malignant. So they will grow in two distinctive patterns inside the uterus: bulky, fleshy masses that invade the uterine wall, or polypoid masses that project into the uterine lumen. So they can go inside the cavity of the uterus or they can go inside the wall of the uterus. How do you distinguish between the benign leiomyoma and the malignant leiomyosarcoma? Because sometimes, even though they are different tumors, sometimes they are difficult to distinguish from each other, especially if your leiomyoma becomes very big, that it will cause bleeding of the other tissue structures near it. So these are the three characteristics which are going to make your lives easier in order to distinguish your benign from your malignant. Malignant will have nuclear atypia, mitotic index of 10 or more mitosis per 10 high power fields, and the presence of tumor necrosis. So again, these three criteria will distinguish the benign from the malignant. Leiomyosarcoma. So this is another high power view of leiomyosarcoma. The ones encircled in yellow, those are your atypical mitotic figures. So again, to differentiate it from benign, you must see 10 or more mitosis per 10 high power fields, nuclear atypia, and your necrosis as well. Next will be endometrial carcinoma, most common invasive cancer of the female genital tract, And you have two types. You have your type 1 or your endometrial, and you have your type 2 known as your serous. I will not discuss the two types in detail since this is in the textbook and it was already discussed in the lecture. Endometrioid adenocarcinomas may have three gradings: well differentiated, grade 1, moderately differentiated, grade 2, and poorly differentiated, grade 3. Well differentiated means almost 100% made of well-formed glands, while your moderately only 50% are well-formed glands, and in poorly differentiated, almost 100% is made up of your solid growth pattern. The first picture, the one on top, the one on your left upper corner, that will be your gross picture. And just to help you identify, this will be your malignant tumors already. Okay? Even this one here. Those are already malignant. Letter B, that is your well differentiated endometrioid adenocarcinoma or carcinoma because you see a lot of well-formed glands. While in letter C, you see that the well-formed glands occupy only about 50% or less of the entire slide. And in the last one, letter D, the entire slide is almost composed of almost 100% of your solid tissue growth. So difference is in letter B, well-formed glands present. Letter C, only about half are composed of well-formed glands. And in letter D, almost 100% composed of solid tissue already. You barely see normal glands or even abnormal glands anymore. What you see will be mostly your solid tissue. This is a picture of our actual slide in the laboratory. So you have your, let me encircle it, you have your atypical areas already. And this would be your well differentiated or type or grade 1 endometrial carcinoma. So you have atypical glands which will also invade the myometrium. And if you look closer, this is high power. You can see that there is already nuclear certification because instead of the simple columnar epithelium, which is found in glands, you will see that instead of just one layer of nuclei, you see multiple layers already. That's what you call stratification. And that is already a sign of malignancy. There are enlarged nuclei and prominent nucleoli as well. Let us proceed to choriocarcinoma. This is a malignant neoplasm of trophoblastic cells, and it can be derived from either a previously normal or abnormal pregnancy. And such examples would be extrauterine ectopic pregnancy, the one which can be found in the fallopian tubes or somewhere else. Characteristic laboratory finding will be elevated HCG levels, and if you look at the tumor, they have soft, fleshy, yellow-white characteristic, and they usually have large pale areas of necrosis and extensive hemorrhage. Histologically, it will not produce chorionic villi and consists entirely of proliferating cystotrophoblasts and cytotrophoblasts. You have a lot of mitosis, and most of the time, mitotic figures are abnormal. They frequently penetrate blood vessels, and they invade the underlying myometrium, and they can also go to adjacent structures. So they are very invasive. So these two are examples of what choriocarcinoma would look like in a gross specimen. Again, they are hemorrhagic, and extensively they can be necrotic as well. That's why you see a lot of black portions, those are your necrotic portions, and you see a lot of bloody portions as well. They are very soft, okay, and fleshy, so they can easily crumble when you touch them, and you have to be very careful when you're handling this type of specimen. Under the microscope, this is how they would look like. You have your neoplastic cytotrophoblasts and syncytial trophoblasts as well. And you have a large portion of necrotic and hemorrhagic areas as well. So these are your neoplastic, syncytio, and cytotrophoblasts. These are actual slides in our laboratory. Next one will be acute salpingitis. This can be caused by any pyogenic organism, and in some cases, they can be caused by multiple organisms. Normal causative agents will be either Neisseria gonorrhea or your Chlamydia trachomatis. As you can see in this picture, there is a pus-like formation already. Let me change the color. So this one. This is pus. Yellowish discharge or yellowish exudate. A review, your normal histologic picture of your fallopian tube. So you have your mucosal folds, and the white portion in the middle, those are your, that is the lumen. But if you already have acute salpingitis, your tubal plicae or mucosal folds will be edematous or very plump, and it will have a lot of neutrophils inside the lumen. So very plump, and the one with the dark blue arrow, those are your inflammatory cells. So again, the neutrophils can be found in the lumen, and they can also be found inside the fallopian tube plicae as well. This is Now this picture, this specific slide, you can see a mixture of both acute and chronic inflammatory cells. So you can see neutrophils, and you can also see your lymphocytes as well. So you have both acute and chronic inflammatory cells present. Neutrophil, lymphocyte, lymphocyte. You have a macrophage there. So you can have both chronic and acute inflammatory cells. Let us proceed to the next slide. You have your cystic teratoma, also referred to as dermoid cysts, if what you will find under the microscope will only be skin-like structures, and this commonly involves women of reproductive age. In 10 to 15% of cases, they can be found in both of your fallopian tubes, the left and the right. And grossly, you can find hair and sebaceous material. This type of tumor, it can get very messy if you cut it in the middle or if you try to open it up because of the presence of your sebum. So this is an example of your ball of hair, which is found inside the ovary. About 1% of the dermoids can undergo malignant transformation to squamous cell carcinoma. And I know this was already discussed in the lecture, but as a review, this type of tumor, this is benign by the way, can contain the three germ layers, your endoderm, ectoderm, and the mesoderm. So this is an actual slide. We have intestinal glands present. We have sebaceous gland. We have your stratified squamous keratinizing epithelium as well. So you have your sebaceous glands with a hair follicle. Remember, in histology, sebaceous glands are found near or beside a hair follicle. You have the skin. If it's only skin that you will see, you call that your dermoid. But if you see 2 or 3 of your germ cell layers, you will call that your teratoma. And there is also the presence of intestinal glands. These structures are not normally found in an ovary. So you have cartilage, this one. You have intestinal glands, this one. You have your sebaceous glands, this one. You even have adipose tissue, and you have your lymphocytes. Please review which ones are considered as your endoderm, ectoderm, and mesoderm. But all of this, they are considered abnormal, okay? All of these structures, they're not supposed to be normally found in an ovary. Polycystic ovary, multiple cystic structures. That's why this ovary in front of you, it has a lot of holes because it has a lot of cysts. This is caused by increased androgen, menstrual abnormalities, polycystic ovaries, chronic anovulation, and decreased associated with decreased fertility. This is associated with mostly females who are obese, who have type 2 diabetes, and have premature atherosclerosis. This is an actual slide in the laboratory. So you will have multiple cysts present. Textbook picture of a follicular cyst and our actual slide. You can see the single layer of granulosa still. Ovarian endometrioid carcinoma accounts for approximately 10 to 15% of all ovarian cancers. And 15 to 30% of this are accompanied by carcinoma of the endometrium. So if you have a patient with endometrioid carcinoma of the ovary, make sure that you check the endometrium as well. And 15 to 20% of cases of endometrioid carcinoma has endometriosis as well. So endometriosis, endometrioid carcinoma, and ovarian endometrioid carcinoma. This is how it would look like. They would look like your endometrial carcinoma, but they are just found in the ovary. So closer view. Next one, we have ovarian papillary serous cyst adenocarcinoma. Over 50% of ovarian epithelial tumors are of this diagnosis. Risk factors for malignant serous tumors are the following: nulliparity, family history, and mutations in your BRCA1 and BRCA2. By the way, BRCA1 and BRCA2, they are also involved with your breast cancers. And this is how they would look like. They have papillary structures, such as this one. Closer view, your papillary structures will have blood vessels inside, such as these ones here. The next tumor are your granulosa cell tumors. They are composed of cells that resemble the granulosa cells of a developing ovarian follicle. For this last few slides, you have to go back to your histology. They are broadly divided into two groups. You have your adult and you have your juvenile granulosal tumors. And this will be based on the age of the patient. So if you have postmenopausal women or older women, you call that your adult granulosal cell tumors. And actually, your adult granulosal cell tumors or your GCTs are the most common between the adult and the juvenile type. So they make up 95% of your GCTs, and a lot occur in postmenopausal women. Inhibin is associated with GCT, and this biomarker is useful for the diagnosis. They are usually unilateral and vary from microscopic foci to large, solid, cystic, encapsulated masses. Tumors that are hormonally active have a yellow coloration due to their intracellular lipids. So if you see yellow coloration, think of a hormonally active tumor. The granulosa cell component of these tumors has many histologic patterns. Occasionally, you will see small, distinctive, gland-like structures filled with an acidophilic material, and you call that your Karl-Exner bodies. They are similar to your immature follicles. If you see these structures, then you can immediately diagnose this as your GCT. So this is our actual slide in the laboratory. The ones pointed by the yellow arrow, those are your Karl-Exner bodies. You can still see the pink or the acidophilic material inside. Actually, there are a lot present in this specific area. So if you see this, you can already diagnose this as your GCT. It will only differ if your patient is an adult, so you call that adult, or your patient is a child, and you will call that your juvenile. Next one is your yolk sac tumor. This is also known as the endodermal sinus tumor. They are not that common, but they are still considered the second most common malignant tumor of germ cell origin. They are derived from malignant germ cells that are differentiating along the extra-embryonic yolk sac lineage. They are similar to the normal yolk sac in that they still elaborate alpha-fetoprotein. So this can be your marker. The characteristic histologic feature is a glomerulus-like structure composed of a central blood vessel enveloped by tumor cells, and you call that your Schiller-Duval body. How to differentiate it from your GCT? GCT, the middle portion, you will only have acidophilic material. For this one, it is already a blood vessel. There is also conspicuous intracellular and extracellular hyaline droplets present in all tumors. And some of this will stain for alpha-fetoprotein if you use immunoperoxidase techniques. So again, like the normal yolk sac, this will also have alpha-fetoprotein. This is our actual slide in the laboratory. You have your tubulopapillary sinusoidal structures with a central vascular core. The lining epithelium can vary from cuboidal to columnar. So closer view, you have two types. It can be seen like this, or it can also be appreciated like this. So you have glomerulo-like structures with a central blood vessel present. Please review the slides in the laboratory. You can also use iLearn to review further. Use your textbooks, and you can always repeat this PowerPoint or this audio recording for reference. Again, do not forget to read your textbooks and study well. Good luck, everyone.